Bismillahirrahmanirrahim. Assalamu alaikum and good morning. We'll be discussing our new guidelines of atrial fibrillation, and I would like to start this video conference by one verse from Holy Quran. That's Allazina amanu wa tatma'innal qulubuhum bi zikrillahi. Ala bi zikrillahi tatma'innal qulub. Those who believe that the hearts they get comfort by the zikr, by the remembrance of Allah, and the remembrance of Allah give comfort to hearts. So this is basically European Society of Cardiology guidelines for the management of atrial fibrillation. They were just released in August 2016. So the key considerations in this regard are that all of us, we are aware that atrial fibrillation is a very common, serious and important condition, and its prevalence is increasing exponentially. The thing is that it's clinically often silent, particularly in elderly and in patients who have heart failure or a history of stroke or TIA. Stroke, myocardial infarction, and heart failure are more common in atrial fibrillation patients. So we can see here that that's the rhythm strip, how it looks like. There is irregular distance between the complexes and no obvious P waves are seen. About 10 to 40% of patients, they are diagnosed with atrial fibrillation every year, and it's independently associated with about twofold increase in all-cause mortality in females and about 1.5-fold increase in men. Patients with atrial fibrillation, they are usually old and they carry significant comorbidity and a high risk of cardiovascular events. So atrial fibrillation remains one of the major causes of stroke, heart failure, sudden death, and cardiovascular morbidity worldwide. Now, the cardiovascular morbidity and mortality associated with atrial fibrillation. So this include, as we can see, death, stroke. So 20 to 30% of ischemic strokes are because of atrial fibrillation. 10 to 40% of hospitalizations are again because of atrial fibrillation, and quality of life is impaired, and left ventricular dysfunction is found in about 20 to 30% of atrial fibrillation. It has also been seen that cognitive decline and vascular dementia has been found more in atrial fibrillation patients as compared with the patients of the same age group. And their brain matter, it has been seen that there are certain lesions which was found on CT scans. So here in 2016 guidelines, the emphasis is on early detection of asymptomatic silent atrial fibrillation. So the diagnosis, it requires an ECG, that's class 1B, and the value of atrial high rate episodes which are picked up by the implanted devices are still not very clear at the moment. So silent undiagnosed AF is a common cause of stroke, as all of us, we are aware about that. And the guidelines, they recommend both opportunistic and targeted intensive ECG screening for atrial fibrillation in all the patients who are above the age of 65 and those who have stroke or a TIA. Again, the recommendation is class 1B. Now, screening for atrial fibrillation. Again, as I discussed, that opportunistic screening for all the patients who are more than 65 years of age by taking a rhythm strip or at least by taking a simple pulse check. And the patients who have a TIA or ischemic stroke, screening for AF is recommended. ECG recording followed by continuous ECG monitoring for at least 72 hours. And it's also recommended to interrogate any pacemakers or ICDs on regular basis to know about the atrial high rate episodes. And the patients who are noticed to have atrial high rate episodes, they should undergo further ECG monitoring to document the atrial fibrillation before initiating any atrial fibrillation therapy. That's again grade 1B. In stroke patients, additional ECG monitoring by long-term invasive ECG or implanted loop recorders should also be considered in patients with silent AF. That's class 2A, level of evidence B. Systematic ECG screening may be considered to detect atrial fibrillation in patients who are more than 75 years of age or those at high risk of stroke. Now, management of atrial high rate episodes if they are detected by implanted device. So how to proceed? So that there is an algorithm that the patients without known atrial fibrillation, if they present with atrial high rate episodes, that's about episode of 5 to 6 minutes of a heart rate of more than 180 beats, if that's detected by an implanted device, then we have to assess the eligibility of oral anticoagulation using the popular Chad's-Vasc score. Now then we have to verify the presence of atrial fibrillation by ECG. That's mandatory. That's a rest. It could be a resting ECG, an ambulatory ECG recorder, patient-operated devices, or review from of the device electrocardiograms. If we see that patient Chad's-Vasc score is low, so patient doesn't require antithrombotic therapy. But of course, if the Chad's-Vasc is high, then we have to verify AF by one of the following criteria which I discussed with you. If again atrial fibrillation is diagnosed, the patient is supposed to be started on oral anticoagulation. If no atrial fibrillation is detected, consider patient characteristics. For example, stroke risk score or the patient preference. Now, classification of atrial fibrillation. Patterns of atrial fibrillation, they are said to be first diagnosed if atrial fibrillation has not been diagnosed before, irrespective of the duration of the arrhythmia or the presence of severity of AF related symptoms. So that's called as the first diagnosed atrial fibrillation. Then paroxysmal, it's a self-terminating. Most of the cases they terminate within 48 hours, but some up to 7 days. So it's called paroxysmal if it's cardioverted within 7 days. Persistent if it's longer than 7 days. Long-standing if it's more than 1 year. And permanent AF is accepted if AF is accepted by the patient and physician. So no interventions for the rhythm control will be made. But if we try to make any further intervention with regard to rhythm control, then we cannot call it a permanent AF. Then we have to call it as a long-standing AF. Now the clinical types of atrial fibrillation. They can be depending upon the pathophysiology and the clinical presentation. For example, an AF due to structural heart disease, a focal AF, polygenic, post-operative, AF in athletes, monogenic, and because of mitral stenosis. Now the symptom burden in atrial fibrillation, that's from the modified European Heart Rhythm Association symptom scale. It's called 1 if there are no symptoms, 2A mild, that the normal daily activities are not affected, 2B is moderate, that normal daily activities are not affected by symptoms related to AF, but patient do have been troubled by the symptoms. 3 is severe, that normal daily activities are affected, disabling, normal daily activities are discontinued. Initial management of a newly diagnosed atrial fibrillation, heart failure and atrial fibrillation. So it's very important that the most important thing is that if you see that patient is unstable, so what to do? It's easy, cardiovert. Anticoagulate depending upon the Chad-Vasc score, and if of course it indicates the risk of stroke. Normalize the fluid balance with diuretics. Control the rate. The target heart rate is less than 110 beats per minute. Then inhibit the renin-angiotensin-aldosterone system. Early consideration of rhythm control is important. Advanced heart failure therapies, which include devices, and treatment of other cardiovascular diseases, especially ischemia and hypertension. Now, acute and chronic management of atrial fibrillation patients and desired cardiovascular outcomes and patient benefits. Now, the treatment, if we go for the acute rate and rhythm control, hemodynamic instability is sorted out and the patient becomes hemodynamically stable. This definitely improves the life expectancy. If we manage the precipitating factors, for example, the lifestyle changes, treatment of the underlying cardiovascular condition, so cardiovascular risk reduction is there. It improves the symptoms as well as the life expectancy. Oral anticoagulation prevents the stroke, so improve along with the symptoms the life expectancy. Then comes the rate control and antiarrhythmic drugs. They are basically more of importance for the symptom control. Now, stroke prevention therapy in atrial fibrillation, patient's prediction of the Chad-Vasc score. Chad-Vasc is congestive cardiac failure. Point is to be given as +1, hypertension +1, age above 75 years +2, diabetes mellitus +1, previous stroke or TIA +2, vascular disease +1, age between 65 to 74 years +1, and if it's a female there is an additional score of +1. Now, stroke prevention in atrial fibrillation, that's the most important thing. Now, if the patient is having mechanical heart valves or moderate or severe mitral stenosis, then patient has to take vitamin K antagonist. If no, then we have to estimate the Chad-Vasc risk. If it's 0, so no antiplatelet or anticoagulant treatment is required. If it's 1, so oral anticoagulants should be considered. If it's more than 2, so they are definitely indicated. We have to assess for the contraindications. So if the contraindications are there or the bleeding risks are high, so we have to correct the reversible things and the patient either can go for the left atrial appendage occlusion device or the non-vitamin K dependent oral anticoagulant. That's the preferred one, or the vitamin K antagonist. Now, recommendations for stroke prevention in patients with atrial fibrillation. So that's oral anticoagulation therapy is recommended to prevent the thromboembolism complications if the patient CHA2DS2-VASc score is 2 or more. That's class 1A. Then oral anticoagulation to prevent thromboembolic in a female patient if it's 3 or more. Again 1A. Then oral anticoagulant therapy to prevent thromboembolism should be considered if the score is 1 in a male and 2 in a female. That's class 2A. Vitamin K, if we decide to start vitamin K antagonists, then the INR should be kept between 2 to 3 or higher. And it's recommended class 1A, 1B if the patient has moderate to severe mitral stenosis. When oral anticoagulation is initiated in a patient with AF who is eligible for NOAC, that's a non-vitamin K dependent oral anticoagulants, then it's recommended to start the patient on NOAC in preference to vitamin K antagonist. It's again class 1A. When patients are treated with a vitamin K antagonist, the TTR, that's a time in therapeutic range, should be kept as high as possible and closely monitored. AF patients already on treatment with a vitamin K antagonists may again be considered for an NOAC treatment if its time thrombo TTT, that's the time in therapeutic range, is not well controlled. It's class 2B, level of evidence is A. Then the combinations of oral anticoagulant and platelet inhibitors, which increases bleeding risk, and it should be avoided in AF patients without another indication for platelet inhibition. In a male or female atrial fibrillation patients without additional stroke risk factors, anticoagulant or antiplatelet therapy is not recommended. It's harmful. 3. Antiplatelet monotherapy is not recommended for stroke prevention in atrial fibrillation patients regardless of stroke risk. It's again harmful. A NOAC are not recommended in patients with mechanical heart valves. Level of evidence is B, or moderate or to severe mitral stenosis. Now, left atrial appendage occlusion and exclusion. Now, the recommendations are that after the surgical occlusion or exclusion of left atrial appendage, it is recommended to continue anticoagulation in at-risk stroke patients with atrial fibrillation. That's class 1, level of evidence B. Left atrial appendage occlusion may be considered for stroke prevention in patients with atrial fibrillation and contraindications for long-term anticoagulant treatment. That's class 2B. Now, the surgical occlusion or exclusion of left atrial appendage may be considered for stroke prevention in patients with AF who are undergoing cardiac surgery. That's again 2B. And surgical occlusion or exclusion of left atrial appendage may be considered for stroke prevention in patients undergo thoracoscopic atrial fibrillation surgery. So if the patient is undergoing any kind of surgery and the patients in whom the bleeding risks are high, so it's class 2B indication to go for left atrial appendage occlusion. But even if LA occlusion has been done and the patient's stroke risk is high, so the patient has to be on oral anticoagulation. So that's the moral of the story. Now, the secondary stroke prevention. Initiation or continuation of anticoagulation in atrial fibrillation patients after stroke or transient ischemic attack is recommended. Then initiation or resumption of anticoagulation in atrial fibrillation after an intracranial bleed, which is quite a tricky situation. So we'll talk about reinitiation of oral anticoagulation after a stroke. So there is an algorithm given. The patients with atrial fibrillation and acute TIA or ischemic stroke, exclusion of intracranial bleeding by CT or MRI. If it's a TIA, so it can be started, the oral anticoagulation, after 1 day of the acute event. If it's mild stroke, NIHSS is less than 8, so then again we have to assess that there are certain factors which favor the initiation of oral anticoagulation, and there are other factors which favor delay in initiation of oral anticoagulation, and it depends on the stroke, whether it's mild if NIHSS less than 8, moderate if NIHSS between 8 to 15, and severe if NIHSS more than 16. So we'll talk about the factors which favor the early initiation. They are low NIHSS score. It's if there is small or no brain infarction on imaging. If there is a high recurrence risk, for example, a cardiac thrombus is there on echo, there is no need for percutaneous endoscopic gastrostomy, no need for carotid surgery, no hemorrhagic transformation, patient is clinically stable, a relatively young patient with a good blood pressure control. And the factors which favor the delay in initiation of OAC are a high NIHSS score, large, moderate brain infarction on imaging, patient needs a gastrostomy or carotid surgery, or there is a hemorrhagic transformation, patient is neurologically unstable, an elderly patient, or uncontrolled hypertension. So if NIHSS score is low, so it can be started 3 days after the acute event. If it's moderate, so we have to evaluate the hemorrhagic transformation by CT or MRI at day 6. And if there is no such transformation and it's favoring the initiation of oral anticoagulation, so they can be started 6 days after the acute event. While if we see that NIHSS score is high or there is hemorrhagic transformation by CT or MRI at day 12, so then at day 12 when the score was high, then 12 days after the acute event, the newer oral anticoagulation can be started. Now that's the more tricky situation, that when to start it after an intracranial bleed. So patients with AF suffering from an intracranial bleed, so if acute event, we have to establish the intensity of anticoagulation. If of course there is any contraindication to oral anticoagulation, so we can go for left atrial appendage occlusion, grade 2B/C, but no stroke protection because there is no evidence for that. And then we have to establish further information. There are certain factors which support withholding an oral anticoagulant, and there are other factors which support reinitiation of oral anticoagulant. So the factors which go in favor of withholding oral anticoagulant are bleeding occurred on adequately dosed NOAC or in setting of treatment interruption or underdosing, older aged uncontrolled hypertension, cortical bleed, severe intracranial bleed, multiple microbleeds, and cause of bleed cannot be removed or treated with chronic alcohol abuse, need for dual antiplatelet therapy after PCI. And the factors which support the reinitiation are if the bleeding occurred on a vitamin K antagonist or in setting of overdose, if the cause was traumatic, if the patient is younger, patient have a well-controlled hypertension, if it was a basal ganglia bleed, there were no or very mild white matter lesions, surgical removal of a subdural hematoma, subarachnoid aneurysmal bleed which has been clipped, or the high risk of ischemic stroke. So the patient next of kin choice informed, and it's a decision of the multidisciplinary team. So initiate or resume oral anticoagulant, choosing an agent with low intracranial bleeding risk after 4 to 8 weeks. So after 1 or 2 months that can be started. Now, management of bleeding events in anticoagulated patients with atrial fibrillation. So the bleeding is that the patient is having active bleeding. Look at the site. If it's compressible, so compress it. Assess the hemodynamic status, the blood pressure, basic coagulation parameters, the blood count, kidney function. Obtain anticoagulation history, last anoic dose or vitamin K dose. If the patient was on vitamin K antagonist, delay the redosing unless the INR is less than 2 in case of minor bleeding. In case of moderate, add symptomatic treatment, for example, fluid replacement, blood transfusion, and treat the bleeding cause, for example, gastroscopy if it's required, and consider to add vitamin K up to 1 to 10 milligram. If it's severe or life-threatening bleed, then consider packed cells, FFPs, and platelets wherever appropriate. If the patient was on a NOAC, so delay for 1 dose for a day. Again, if it's in case of minor bleed, in case of moderate, again symptomatic treatment, and in case of severe or life-threatening, consider the specific antidote or consider replacement of the platelets or whatever is required. Now the combination therapy with oral anticoagulants and antiplatelets. There are only very few situations. For example, if a patient is having acute coronary syndrome, so we have to look at the bleeding risk. If the bleeding risk is low, so a patient can have a triple therapy up to 6 months, then dual therapy for next 6 months, and then oral anticoagulant monotherapy lifelong. If the bleeding risk is high and the patient had a stent, thrombosis, and you have to give triple therapy, then it should be given for 1 month, then dual therapy up to 1 year, and lifelong patient should be kept on oral anticoagulant. Antithrombotic therapy after elective percutaneous intervention in atrial fibrillation patients requiring anticoagulation, so that we just discussed about it. Now, rate control therapy in atrial fibrillation. So acute heart rate control. If the patient, it depends upon the LV ejection fraction, whether it's more than 40% or less than 40%. For more than 40%, a beta blocker, delta-ASM, verapamil can be used, digoxin can be added, but add bradycardia. If the ejection fraction is less than 40%, then the smallest dose of beta blocker, amidron, remains an option. And the important thing is that the resting heart rate is targeted as less than 110. Digoxin can be added, but again we have to avoid bradycardia for the patient. Now the long-term pharmacological rate control. The rate control again depends upon the ejection fraction, whether less than 40% or more than 40%. If less than 40%, then beta blockers and digoxin are the best choices. If more than 40%, then delta-ASM or verapamil can also be added. Now the acute restoration of sinus rhythm. If it's a recent onset AF and the patient is hemodynamically unstable, we have to go for electrical cardioversion. If the patient is hemodynamically stable, then it's patient's choice. If we want a rhythm control, we have to go for electrical cardioversion. Otherwise, pharmacological cardioversion depending upon the patient choice. If the patient has severe heart failure with reduced ejection fraction and significant aortic stenosis, so the drug of choice is amidron. If the patient again have coronary artery disease, abnormal LVH, So again, amiodarone, but vernaculant is another choice. If the patient don't have any other structural heart disease, then there are a lot many choices. For example, a pill in the pocket, IV flecainide, propafenone, vernaculant, etc. So long-term antiarrhythmic drug therapy. So initiation of long-term therapy in patients with AF, if the patient has no or minimal structural heart disease, is the patient choice, but we can go for catheter ablation or the pharmacological like propafenone and all. The patients with coronary heart disease, again catheter ablation remains a choice, or amiodarone or sutalol can be given. In patients with heart failure, again catheter ablation. So it goes that long-term therapy to improve the patient outcome and symptoms in AF patients is catheter ablation. So the take-home message, if we see that rate control is crucial in atrial fibrillation management. It's background therapy for nearly all the atrial fibrillation patients. No rhythm control treatments are associated with improved survival. The survival is improved only by anticoagulation. But in every symptomatic patient, atrial fibrillation ablation should always be considered. And rate control, again, it may be the first choice in elderly asymptomatic patients or when risks restoring sinus rhythm outweighs the benefits. A lenient strategy is safe, effective, and easy to institute. It is reasonable to initiate first. A stricter approach is indicated if symptoms persist or deterioration of cardiac function occurs. Now, the type of treatment depends upon the age, the activity level, comorbidities, and concomitant drugs. The AV nodal ablation is last resort therapy, but indicated if continuous biventricular pacing is not achieved. Several patient groups deserve special attention. So, now the summary and conclusion. At present, antiarrhythmic agents remain first-line therapy for rhythm control. They are limited by poor efficacy and tolerability. Catheter ablation leads to superior rhythm control. Optimal methods remain unclear for persistent forms of atrial fibrillation. Atrial fibrillation and heart failure increasingly encountered clinical problems. Catheter ablation may lead to improved outcomes. So thank you very much. So that's it. We'll talk about the next session later. So thank you very much. Bye.